And thank you, Dr. Harvey, for introducing her to the group. Appreciate it. Our next prize winner is a winner of the Colvin Prize, and this is a prize for an outstanding achievement in mood disorder research. And our winner this year is Dr. Roger McIntyre. Now, Dr. McIntyre is professor of psychiatry and pharmacology at the University of Toronto. So he's certainly an international representation at this meeting. But this is really only half of the story, really. If you look at, he's at the Krembil Research Institute in Canada. And if you look at his CV, you see that he has professorships literally around the world. He is professor at Guangzhou Medical University in China. He's an adjunct professor in the Korea University in Seoul, South Korea. He's a visiting professor in the Philippines in Manila. And then he even reserves a couple of his professorships for the United States. He's a clinical professor at SUNY in New York and a clinical professor in the University of California, Riverside campus. And I haven't ever seen anybody with this breadth of presentations. I just learned this morning that Dr. McIntyre was really born and raised in Nova Scotia. So maybe he got a little restless in his junior years. This isn't the whole story about Dr. McIntyre. He's authored and co-authored more than 900 publications. And because of that, not only because of authoring so many publications, but also being cited so much, which means that people use his data, he's included in one of the world's most influential scientific minds. So that's really terrific. He is involved in a number of different areas of phenomenology, neurobiology, and novel therapeutics in the area of mood disorders. But what he's going to talk about today is in his title, Does Obesity Metastasize to the Brain, which is a kind of a cute idea. But I just learned this morning also that his research in this direction was originally funded by a Young Investigator Award from BBRF. So welcome, Dr. McIntyre. No, come on.
Thanks, Carol. Thank you so much. Thank you, Carol, so much for that. And an incredible thank you to BBRF and to the committee for considering me. And also pick up on Carol what you said, a thank you to BBRF for originally supporting my research in this area. In fact, it was the area that brought me into psychiatry, the intersection of metabolism and the cause, perhaps the treatment of mood disorders. Dr. Bornstein's first slide still is stuck in my mind this morning when we looked at really addressing two strategic priorities in psychiatry: our thirst, our incredible appetite to suss out the underlying mechanisms of brain-based diseases, and also identify de novo, repurpose therapeutics that are actually innovative, possibly disease-modifying, possibly preventative, possibly curative. And so it's that theme that has always inspired me throughout. I got to thank the patients that have given me this incredible surreal life that I've had. It's been my ambition, it's been my inspiration, it's certainly been my rudder throughout my entire career. Greetings to folks here. Congratulations to my peers who've also had these distinguished awards. So really the theme that I want to come to is the theme of mechanisms and how mechanisms may in fact shape how we may treat, maybe prevent mood disorders in the future. My career actually started off slightly different. One of those provocative questions you're asked at dinner parties is, why did you become a psychiatrist? I think it's often anticipation of maybe a rich story behind it. But my actually story started off in the sense that I started off through medical school. I was in neurosurgery. That's what I was going to do. That's where all my time was spent during electives and so on. That's my residency was going to match. And it was only my obligatory last years of medical school, I had the obligatory compulsory rotation in psychiatry, that a law enforcement brought a gentleman in who was living with bipolar disorder. He was very manic. He struggled with his weight. And I like many types of music. My most favorite is probably classical. And when I saw this gentleman in the emergency room, it was like classical music to me. And I said, I've got to study what this man has. And here I am 30, 35 years later, trying to suss out the link of bipolarity and metabolism. So that's exactly how I end up in this field. So we're going to go through this. I call it the metastasis of obesity and diabetes to the brain. And this is really to speak to the intersection. It's to speak to repurposing. It's to speak to what the BBRF has clearly instantiated through action, and that is just, can we take science and can we offer rapid, innovative, perhaps disease-modifying treatment for people with live condition. Now, people come to this meeting this morning with very different backgrounds. We're going to briefly cover the clinical overlap of mood disorders and metabolism. We're going to be very, very quick on that. We're going to speak to the mechanistic overlap and what this might mean for therapeutics. So this is, when I first started in the field, and I observed what clinicians had observed, and you know, science begins with observation. And yes, we observed that our patients were living with obesity and type 2 diabetes, metabolic syndrome. At the time, that wasn't really a focus in psychiatry at all. And what appeared to me to be the case immediately when I was actually seeing these persons was how impaired they were, on average more so in areas of cognition, social cognition, but also in areas of reward prediction. And it was a curiosity that would never leave me alone, and I was very curious as to why they had a very different presentation. And I took the thought one step further and started to think, maybe these are not disturbances of serotonin. We've been worshiping at the altar of serotonin for 7 decades in psychiatry. Perhaps there's a different way to think about the underlying lesion, maybe a different way to think about treatment and prevention. And the story continues, because what we then discovered was, soon after, is that the most common cause of premature mortality in depression and bipolar disorder was not suicide, was in fact cardiovascular disease. This was a light bulb moment for the field. This is now well replicated. This has inspired calls to action, consensus statements, guidelines, and so on to target not just above the neck, but below the neck pathology. Many reasons why this is the case. And certainly there's not one size fits all explanation why we have an overlap of metabolic problems in people who are living with mood disorders. And I decided throughout my career to focus on, again, a reductive, but one part of this that to me was grabbing my attention, that being the link between insulin, the brain, psychopathology, and what this might mean for novel therapeutics. But this is, in fact, just a reminder, there's many different suspects in the suspect line that are contributing to this comorbidity. We were the first ones in the world to call out the role of trauma and what role that might play, early adversity and childhood trauma, in igniting a cascade of events that would lead to the clinical presentation of metabolic syndrome in people living with depression and bipolar disorder. In a call out to David Muzina, a good colleague at Cleveland Clinic, and I, who did this about 10, 15 years ago. Now, to keep going with this, though, what I want now, if I can, is to cascade down a little bit. We do know that bipolar disorder and major depressive disorder are brain-based disorders, and we know whether we look at structure, volume, or functional connectivity, there are changes. And it has been amply documented now that in, for example, bipolar disorder, there is a loss of brain tissue, especially as a function of disease state in people who are not taking lithium. And what caught my eye very early in my career was the additive effect, if not the independent effect, that's a result of obesity. In other words, when you look at brain structure, brain function, brain interconnectivity, and you look at the scans on this screen, and you put obesity and diabetes on this screen, it's very hard to tell the two screens apart. In other words, the effect that we see in the brain of people living with depression and bipolar disorder looks a whole lot like what we see in people with diabetes and obesity, and when you add the two of them together, you get an additive effect. This was work that we did in Singapore with Sing Kam, a good friend of mine there. We decided, this was a number of years ago, to look at what independent and additive effects were happening in functional connectivity in the brain as a function of obesity. And again, this is how the story started for us. We had no idea that obesity was linked to changes in resting state functional connectivity in the brain. And this was then replicated not only in psychiatry, but was replicated in the world of obesity and diabetes, where I've spent probably as much, if not more, of my career. Now, these are some very prodigious neonates. These neonates signed up for a study. These are like a month old, and they're already starting up for a study. They want $50, I guess. And so they're looking at brain circuits in these neonates in offspring of moms who are obese. And I just wanted to mention this because we are especially interested in the prevention of depression and bipolar disorder. And we are not only talking about the vertical transmission of the mental illness, but also of the physical illnesses that are also having hazardous effects on brain. And just simply put, many of the changes that we see in brain in obese adults living with without bipolar or depression are very similar to what we see in neonates. Now what I want to do is just quickly move along and talk about the phenomenology. So what had happened is I was sitting in my office, just started my career. I had no research experience whatsoever, but I was interrogated by so much curiosity. And I was sitting there thinking to myself, why is this person sitting in my office who's so impaired with bipolar disorder or depression? Why is it that when they are overweight, obese, why is it when they're diabetic, why do we see so much greater deficits in cognition? And this was replicated and replicated and replicated in diabetes, but wasn't really being talked about in the world of psychiatry. We then looked at a younger population. This was actually an ultra-high risk population in China with my colleague at Guangzhou University, showing in fact that in ultra-high risk people, these are kids who don't have bipolar, mom or dad has bipolar, the kid has some type of psychopathology but not yet declared illness of depression or bipolar. These kids, when they were obese, began to have cognitive functions that were more like their parents. And that was something that was in keeping with the thesis that obesity is affecting the brain, and obesity is causing a progression of brain loss, a progression of brain aging. What I want to do, if I can now, is shift from cognition to reward. The two principal reasons why persons who live with depression and bipolar disorder have lost human capital is because of thinking and feeling. Thinking and feeling. There's a deficit in the brain capital around cognition. There's a deficit in reward function. And there's a variety of paradigms that evaluate this aspect of reward function. I think, Phil, you talked about biases that people have and how biases can be affected by mood states. Most of us have what's called an optimism bias. In depression, there's a negativism bias. That is that there are decisions made that are more near-term decisions at the expense of long-term gain. And these are different paradigms called discounting the importance of delaying the gratification. And what's really interesting is that when you look at people who live with diabetes, who live with obesity, they have profound deficits in this area of reward prediction. So remember I said that the anatomy, the circuitry, the functional connectivity of depression and bipolar is almost indistinguishable from what we see in depression and in obesity and diabetes? When you start looking at these paradigms, these motivational paradigms, these cognitive paradigms, social cognition paradigms, they also look very, very similar. So we start off very clinical, we start coming down, we start looking more narrowly at phenomenology. Depression, bipolar disorder, obesity, and diabetes are very, very similar. So this was supporting an idea that we started having. Maybe there's a convergence. Maybe this is explaining why we're seeing the phenomenon we see. A few years ago, I wrote this paper saying that the world is seeing a change in how bipolar presents. Maybe the obesity pandemic is creating a mixed features pandemic. We're seeing not only cognitive impairment, disturbance in how people present, disturbance in reward function, but we're also seeing a much more pernicious presentation of bipolarity. So I thought to myself, we need a new moniker. In the world of dementia, they talk about type 3 diabetes. We need a moniker. We need something that instantiates this concept that the lesion in depression, the lesion in bipolar disorder, among other things, includes aspects of metabolic disturbance. So I introduced this term called metabolic syndrome type 2 to speak to this concept that there's something happening at the cellular, subcellular level in persons living with depression and bipolar disorder that is metabolic. So then we decided to then look at insulin. So insulin, we know, of course, with peripheral glucoregulatory function, insulin in the brain is not required for glucose disposal necessarily. Insulin in the brain serves more of a trophic role, a plasticity role. It serves more of a neuroprotective role. And what's interesting is that when we have states of increased insulin, which happens in early diabetes, what happens is that we have a increased deposition of amyloid beta and tau. And the reason why that is because insulin is broken down by an enzyme, by its namesake, the insulin-degrading enzyme. The insulin-degrading enzyme is a metalloprotease that also breaks down amyloid. So in early diabetes, what happens is you have an increase in insulin. That results in an increased deposition of amyloid because the enzyme is, has a higher affinity for its namesake substrate being insulin. But what happens over time is that as your insulin levels consistently are elevated, the blood-brain barrier then decreases insulin transport to the brain, decreasing trophic support. So in insulin resistance, it's a double whammy. Initially what happens is you get deposition of amyloid at the early years, and in the later years, you actually start seeing changes in neuroplasticity. So how this has context is that 1 in 2 people, 50% of people living with bipolar disorder, are pre-diabetic or they are diabetic. And insulin also serves a potent neuromodulatory role. It's a monoamine oxidase inhibitor, and it is a protein that is critical to motivation in cognitive functions. And we started to conjecture maybe this is something we could target. Maybe we could target it directly, pharmacologically, behaviorally, lifestyle, maybe through surgery. So some good friends and colleagues are here. Rodrigo Mansour is here, who's now become one of the world's leaders in metabolic research, and Josh Rosenblatt's here, one of the world's leaders now in rapid-acting treatments for psychiatry. Rodrigo led this research looking at peripheral exosomes. These are derived from the neuron, showing for one of the very first times ever that there is, in fact, insulin resistance in the brain in people living with bipolar disorder. This has always been a challenge for us. How much does the periphery affect central? Related questions. How can we attack this problem? How can we correct this lesion? Do we do it through behavior and lifestyle? Yes. Do we do it through diet? Possibly. A lot of interesting ketogenic diets. These are areas that have taken off in the field. This is looking at gut microbiota, which appears to be altered in people living with depression and bipolar. This has inspired a lot of work in this field, looking at how this can be targeted directly or indirectly. Amina Ahmad, a good friend and colleague, we did this NIH-supported grant study about 15 years ago at a Kaiser, where we looked at, for the very first time, bariatric surgery in bipolar disorder. I did this study more for advocacy, because at the time, if you had a diagnosis of bipolar disorder, you were excluded from bariatric surgery. And I always thought that didn't seem justified. So we did this primarily to show that it could be safely and feasibly administered, but there's been a lot of interest now in looking at what is the impact on bipolar outcomes with these types of weight loss. So I think it's always important to have a principle or a way to guide your thinking in this. And we've now learned over the years that, among other things, there's an accelerated apoptotic process happening in depression and bipolar disorder, and lithium is probably the most potent anti-apoptotic peptide we have. And I was especially interested in how can we slow down this process early on. So I introduced this term called metaboptosis. Is there something we can do to target metabolism through inflammatory pathways or metabolic pathways to slow this down? We've done some work interventional. This is more proof of concept. This is with an anti-TNF drug. This was supported by multiple organizations to really prove the concept that there may be an inflammatory subtype of bipolar disorder, a metabolic subtype. This is an anti-inflammatory drug that's an insulin sensitizer at the same time. And what was interesting is that in a relatively common subgroup of people who live with bipolar disorder, we found that this subgroup actually benefited from this insulin sensitizing anti-inflammatory approach, a group that does not respond especially well to lithium or other conventional treatments. Way back in the day, and I will thank BBRF for having the vision, when I started looking at insulin in the brain in psychiatry, I think there was a handful of articles at the time. Now we have about 30,000 articles or so in the field. And so I really thank them for their support in the early days after many, many rejections. And this was a very difficult study to do. We did this one. We were able to show benefits and measures of cognitive functions. This is intranasally delivered insulin, which does not affect peripheral glucose. This was extended into major depression, good friend Suzanne Kraft then extended this into Alzheimer's disease, early dementia. And this is then now this whole field's now taking off in the sense of trying to repurpose metabolic drugs to treat brain-based disorders. This was a population-based study showing that metformin, we've had metformin for almost 100 years now, it's an old drug, showing that metformin was one of the few drugs other than lithium that could actually reduce psychiatric hospitalizations in Europe. This was a really interesting study from a colleague in Canada who actually showed that metformin can actually convert people who live with bipolar disorder who are insulin resistant into a more insulin sensitive state, and if they did so, would declare actually an antidepressant response. But where in fact this has been really, really intriguing to see, because we thought insulin was really the use case, it was the start of the conversation to see which targets can we actually come at that are scalable, obviously cost effective, that could actually have a meaningful effect on brain function. And that's taken us down this path now into the area of GLP-1s. Now, before Kim Kardashian got into GLP-1s and everyone else, we were interested in GLP-1s 15 years ago in the sense that GLP-1s produced in the gut, it's a peptide, one of many GI peptides, but it's also produced in the brain, in the nucleus tractus solitarius. It has canonical receptors located in various nodal regions, hippocampus, amygdala, prefrontal cortex, also in cortical areas as well, that we started thinking maybe this could be a potential target for us in people who are living with depression and bipolar disorder. And at the time, there was no work done with GLP-1s at all in brain-based conditions. These are drugs that are developed for diabetes and obesity. But certainly what I was reading with respect to the preclin on this particular protein, and it's you could agonize it with a drug, was speaking loudly of a possibility for us in terms of depression and bipolar. There's now, in fact, been enormous interest in these drugs from the point of view of perhaps even preventing heart disease, diabetes, preventing even non-alcoholic fatty liver disease, preventing even dementia, and also some just suggestions that can even be preventing depression in a variety of paradigms. These drugs are of enormous commercial success. In fact, one of the sponsors, Novo Nordisk, based in Copenhagen, these products have increased the GDP of Denmark. It's unthinkable, the amount of interest in these products. Just for those maybe a little less familiar, we in the area of psychiatry have got to get into the prevention business, and we've got to be preventing the cognitive decline. And again, you can learn so much translationally. In the world of diabetes, there is many, many studies now to show that these agents are slowing cognitive decline. Cognitive decline is a big, big problem in diabetics and people with obesity, and this has been observed over and over again. It adds to this thesis that perhaps these drugs have beneficial effects cognitively. GLP-1s are drugs that increase insulin secretion and release, but they also have direct effects on the brain, and they modulate neurotransmitters, they modulate plasticity. This is a study just simply indicating that when insulin begins to struggle in people who are overweight or obese, GLP-1 sort of steps in as a pinch hitter, and it is able to return normal dopamine tone back into the brain. We decided what we would do is get right into therapeutic research with these agents. A good colleague of ours, Gung-Soo Kim in Korea, ran this data for us, and we said, let's look at animal models of depression, and let's look at GLP-1. And we first proposed this, everyone was like, what are you talking about? These are diabetes drugs and so on. What was really interesting is that in this immobility model, when we gave them GLP, it reversed the immobility, and when we gave these animals NBQX, which blocks the AMPA system, we couldn't get the reversal of immobility. That suggested there was something going on with glutamate. We thought that this effect was in part mediated through glutamate, and this effect was happening immediately. So in addition to thinking about a metabolic therapeutic, we thought in part this involved neuroplasticity processes, including E.G.glutamate, and was doing so very, very rapidly. Rodrigo led this campaign in terms of looking at the improvement in cognitive functions. This was the first study in the world ever to look at GLP-1 as a putative therapeutic in people with depression and bipolar disorder. I've often said that these are psychiatric drugs that masquerade as weight loss and diabetes drugs, and the sponsors of these drugs are actually developing them now for mental illnesses, including not limited for Alzheimer's disease. And what's really interesting is if you look at markers of neuronal viability like NAA, we do in fact see that there are changes occurring in brain. So there is a direct effect happening in brain with these therapeutics. And then to just around the base a little bit here, there's been now study after study after study showing that these drugs are benefiting measures not only of motivation, measures of reward decision, but also measures of cognition. And finally, Rodrigo's leading this study at our center. This is the first study in the world like this, and this is about changing the paradigm. Can we actually, just like esketamine, targeting glutamate, brexanolone on GABA, can we actually take the mechanism, put the horse in front of the cart, and use that to come up with what we desperately need is therapeutics now. New therapeutics, de novos or repurposed, targeting. And this whole paradigm has been built around an observation that what we see clinically, what we see endophenotypically, what we see neurobiologically in diabetes, obesity, and mood disorders is overlapping, and that in fact could mean something for cross therapeutics. One final slide. This is a new drug in America called Mounjaro. It is a coagonist. It's a drug that has both GLP and GIP. GIP is an insulinotropic peptide that also has location in the brain relevant to us in psychiatry. Now there's even triagonists. These drugs cause more weight loss than anything we've seen in the history of therapeutics. These drugs cause more weight loss than bariatric surgery in many studies. And these drugs are causing significant protection in brain, especially in regions of cognitive control and reward processing. And we are in discussions with a few organizations right now with actually funding what will be the world's first study testing Mounjaro as a potential treatment for depression and bipolar disorder. So science begins with observation. I sat with a patient in my office at a time when no one talked about diabetes in the brain in psychiatry. And for about 7-8 years, I reached out to different organizations to fund research looking at metabolism in the brain. And most of the feedback I received from organizations was, this is an interesting idea, but I don't get it. And now here we are 30 years later, thanks to BBRF supporting this research. This research has skyrocketed with tens of thousands of articles. It's probably one of the hottest areas in the world right now, and it's inspired not just the public sector, but the private sector to develop therapeutics to target this, and I really, really think that this is going to actually open up a new drop-down menu of therapeutics for people living with depression and bipolar and potentially preventative treatments. Thank you.
Thank you. 2 questions. One is, the medications for bipolar, at least the way I interpreted them, often would give a caution about bringing on the onset of diabetes. And I always concluded that it was the medication that was doing that. And are you saying now that no, what this might do is trigger or add to what's already there?
Such a good point, and you're absolutely correct. We have 5 major classes of drugs that we prescribe in bipolar disorder, 2 major, or maybe 3, but 2 major classes in major depression. Many agents within the class independently affect glucose and lipid homeostasis, independently can cause weight gain. That's independent of the disease state. But in addition to the iatrogenic effect, the drug-induced effect, there are aspects about the disease state, that are intrinsically abnormal with respect to metabolic function and weight function. Ben Goldstein's here, my closest friend, has done world-leading research looking at how vascular disturbance is intrinsic to bipolar disorder. In addition, what we do know is that there's the behavior, that is the sleep disturbance, the habitual inactivity contribute, and we also know that there are comorbidities that also contribute to it as well. So the medications play a role, but what we do know is that metabolic changes, or broadly cardiovascular metabolic changes, are innate to the condition. Now, in a simple world, this model would apply to every single person living with bipolar disorder or major depression. It does not. It applies to a subpopulation of people who live with depression and bipolar disorder. And it is really the future that we need to kind of fractionate and subgroup this, come up with more homogeneous subpopulations. That will help us guide, I think, more personalized therapeutics. But the weight aspect is in part medication, but that doesn't explain the whole story.
Okay, and then my second question, there's been a look in terms of the study of Alzheimer's, where they're looking at the insulin levels in the brain. Yep. And if you've looked at that, can you talk about that?
So what we've done, and Rodrigo's led this. This is on the cusp research, and that is that it's hard to get a brain biopsy for reasons obvious. So you can infer by looking at different approaches. One is to use exosomes, which are neuronally derived, and these exosomes are thought to recapitulate the cellular and molecular environment of the brain. And with a good friend, Dimitrio Karigianis at NIH, what we've done is, Rodrigo led this, is to look at insulin sensitivity in the brain as indexed by using exosomes. And what we showed for the very first time in the world, in bipolar disorder, there is insulin resistance in the brain. And so we think that is a mechanism. We think that's not necessarily a state. We think it's trait. And we have reasons to believe that because metabolic problems in people who live with mood disorders are in the family. They're in people who are living, who are unaffected by depression and bipolar disorder as well. So yes, we do think that is the case. And by the way, to keep that going, I had a quick figure I showed wherein I had a figure what insulin. I mean, insulin is the most incredible pharmaceutical, quite frankly, with respect to its neuroprotection, its neuroplasticity, it's anti-apoptotic, it is neuromodulatory. This would be a blockbuster drug if it could be on its own, and it became one for diabetes. But what we do know is that in people who live with Alzheimer's disease, 80% show insulin insensitivity. 80% show insulin sensitivity. And once you have insulin insensitivity, it triggers the deposition of amyloid. It triggers the phosphorylation of tau, two markers known in the world of major neurocognitive disorders, but two markers that we see deposited at high levels in people who are 30 and 40 years old with mood disorders. So we think this is a convergent mechanism. There's ways that we can reset that, either through behavior, through weight loss, through diet, through pharmacology. Insulin can be modulated directly and or indirectly through the GLP-1 system.
So while
they do. So a very good friend, Lars Kessing in Denmark, has shown that if you live with bipolar disorder and you have multiple episodes of illness, the hazard for Alzheimer's disease increases for each episode if you're not taking lithium. If you take lithium, the risk is no different than the general population. And when we start to unravel the mechanism of lithium, the mechanism of lithium overlaps with the mechanism of insulin. So in the cellular system, lithium and insulin have a very, very similar effect.
While you're bringing this microphone down to this lady here, I want to ask just a simple question, Roger. There's now blockbuster drugs for weight loss. Now it has nothing to do with diabetes, has nothing to do, you know, the couple of them that all of our friends are taking. Are we supposed to
Vitamin O, Ozempic.
Yeah. Are we supposed to be thinking of these as mood disorder drugs? next.
Yeah, there's no question. You know, it's interesting that these drugs have first come out and tested in the world of diabetes and more recently, you know, overweight, obesity. And we have now come to learn that GLP has a direct role in the central nervous system. And again, we are at the Brain and Behavior Research Foundation meeting, and we are talking about the brain. And what's interesting about this class of drugs is that they have effects well beyond metabolism, and including the brain. And when we begin to really look carefully in the brain, we have molecular work, cellular work, structural work, some of the functional work, what these proteins do in the brain is that they reset cognitive control. They're important for salience. They're important for reward and motivation. So when I hear, you know, I take the Willie Sutton.
Is that the drug or is that the weight loss?
Well, both. And so the mechanism of the weight loss is not fully characterized, but it is now accepted that diabetes is influenced by the hypothalamus. So stimulating the brain affects peripheral insulin sensitivity. And we also know that stimulating the brain affects aspects of obesity. And Nora Volkow has shown, and she's argued, that obesity should be included as a brain disease. And so we have convergence. So you have the Venn diagram of obesity, you have diabetes, and you have mood disorders, and they're converging at every unit of analysis as we go down. So it's very, very intriguing.
One more question.
Yes. I'm a board member and I'm a layperson, and I understood almost half of everything you said, which was pretty good. So that's where I come from. But my doctor last year told me that I was missing glucagon and put me in Ozempic, and so Kim Kardashian and I have that in common. So I just wanted to thank you for what you've been doing. I don't even know what question, because I have so many questions, I don't even know what I want to say to you. But I'm glad that the drug is helping my brain. I mean, that's really wonderful, not only my body. And thank you so much.
I appreciate that. But, you know, the way I would put it, and you know, what happened is that psychiatry historically and culturally and politically has operated in silos for a long time for many reasons. And it's very, very clear that psychiatric disorders broadly are multi-organ. And sometimes you can learn a lot about your organ of interest, being the brain, by looking at an adjacent organ. And when you find a lot of points of similarities, you can kind of translate that over. And clinically, when I met so many people who were overweight and diabetic, I started noticing that their illness was different. And we started to dig deep and dig deeper and dig deeper, and we found there was something different in the brain. And that then was a light bulb moment. Maybe we could repurpose the weight loss and diabetes drugs over to us. And maybe there's something we can gain from that. And that's sort of the simple story, but that actually is how I thought it through. And the original work that we did, looking at obesity and diabetes, we showed that the brain was getting smaller. And I was running around the world saying the brain's getting smaller. Then someone yelled out, size doesn't matter. Well, okay, well, we started looking at circuits and functional interconnectivity. So I am now convinced this is a tremendous opportunity. Again, this all goes with an instinct. And BBRF was ahead of the curve. S-ketamine is revolutionary in psychiatry, in ketamine. Now, its commercial success is a different story, but it's changed the game. We now have rapid onset treatments to treat postpartum depression. It's changed the game. And we are in a position now, based on what we now know about this area, that there are potentially disease-modifying ways we can treat depression with these therapeutics. Will it be these drugs I'm talking about today, insulin and GLP-1? I don't know. But these are the use case. This gets us into that zip code of thinking about this.
Roger McIntyre, thank you so much.
Thank you. Thank you.